Bismillahirrahmanirrahim. We shall explain you today the renal function test and the diagnosis of renal disorders. In this context, the objectives of our lecture are to explain you urine analysis, blood examination, glomerular function test, renal clearance test, and the tubular function test. In this context, before we go in details of renal function test, first of all, we shall explain you why renal function tests are performed and when shall we assess renal functions. In this context, renal function tests are performed to assess the functional capacity of kidney. And renal function tests are performed for early detection of possible renal impairment. And renal function tests are performed to assess severity and the progression of renal impairment, and to monitor response of treatment, and to monitor safe and effective use of drugs which are excreted in the urine. Now, when should we assess renal functions? So assessment of renal function test is important for the old age people and when there is family history of chronic kidney disease, patients with decreased renal mass. Renal assessment is important in diabetes mellitus, in the hypertension, in autoimmune diseases. They are important in systemic infections. They are important in urinary tract infection, nephrolithiasis, and obstruction of lower urinary tract, and in drug toxicity. Now, the functional unit of kidney is called nephron. And there are approximately 10 lakhs to 30 lakhs nephrons in each kidney. A nephron consists of glomerular capillary network, Bowman's capsule, proximal tubule, loop of Henle, distal tubule, and the collecting duct. And the renal function tests, they give us information about the renal blood flow. They give us information about the glomerular filtration rate, renal glomeruli function, renal tubular function, and the urinary output. Then these kidneys, they are performing many important functions. Kidneys, they are performing excretory functions. They are performing homeostatic functions. They are performing endocrine function, and they are performing metabolic functions. So as far as the excretory functions of the kidney are concerned, kidneys, they play a role in the formation and the excretion of urine. So in this process, in the formation and excretion of urine involves glomerular filtration, tubular reabsorption, and tubular secretion. Kidneys play a role also in the excretion of toxic substances such as urea, uric acid, and creatinine. Then kidneys, they perform homeostatic function. In the homeostatic function, kidneys, they play a role in the regulation of blood pH. They play a role in the regulation of blood volume, and kidneys play a role in the regulation of serum electrolytes. That is, play a role in the regulation of sodium, potassium, chloride, and calcium. And they also play a role in the reabsorption of essential nutrients. And kidneys, they also perform endocrine function. In the endocrine function, they play a role in the formation of erythropoietin. They play a role in the formation of renin-angiotensin system. They play a role in the activation of vitamin D. So what is erythropoietin? Erythropoietin is a glycoprotein. In the fetal life, erythropoietin is synthesized in the liver, while in the adult life, it is synthesized in the kidneys. Site of synthesis of erythropoietin is endothelial cells of particularly peritubular capillaries. Erythropoietin stimulates erythropoiesis by acting on erythroid progenitor cells in the bone marrow. It induces cell division and cell differentiation. Hypoxia is main stimulator of erythropoietin secretion by kidneys. Erythropoietin deficiencies exist in chronic renal disease that explains the observed anemic conditions in such patients. Then kidneys, they play a role in the renin-angiotensin system. What is renin? Renin is a glycoprotein consisting of 340 amino acids. It is synthesized in the juxtaglomerular apparatus. Renin is a protease which catalyzes hydrolytic cleavage of decapeptide angiotensin 1 from the angiotensinogen. Renin acts on angiotensinogen to form angiotensin 1. Angiotensin 1 is converted angiotensin 1 is converted to angiotensin 2 by angiotensin converting enzyme. Aldosterone retains sodium and maintains plasma volume. Raised potassium level tends to increase aldosterone secretion through renin-angiotensin system. Then kidneys, they play a role in the activation of vitamin D. Vitamin D is formed from cholesterol. In the cholesterol, there's 7-dehydrocholesterol, which is on exposure to sunlight is converted into cholecalciferol. This cholecalciferol, then it is transported to the liver, where it is hydroxylated at carbon number 25, and it is converted into 25-hydroxycholecalciferol. 25-hydroxycholecalciferol is then transported to the kidneys, where it is again hydroxylated at carbon number 1 by the enzyme 1-hydroxylase and changes 25-hydroxycholecalciferol into 1-25-dihydroxycholecalciferol. That is active vitamin D, which plays role in the calcium metabolism, plays important role in the absorption of calcium from intestine. And then kidneys, they are also performing metabolic functions. In the metabolic function, they play a very important role in the gluconeogenesis. Gluconeogenesis is the process for the formation of glucose or glycogen from non-carbohydrates. Formation of glucose from glycogenic amino acids, formation of glucose from lactate and glycerol are the non-carbohydrates which are converted into glucose in the liver and in the kidneys. So, like liver, kidney is again a very important site for gluconeogenesis, for the formation of glucose or glycogen from non-carbohydrates. Then, what are the causes of renal diseases? So, causes of renal diseases, they are divided in pre-renal, renal, and post-renal causes. So, the pre-renal causes of the renal disease include any condition that results in the reduced blood flow to the kidney, like severe blood loss or hemolysis. Then renal causes of renal disease include damage to renal tissues or glomerular basement membrane or damage to tubules. Such situation is seen in glomerular nephritis, diabetes nephropathy, and in tubular damage due to toxic substances. And the post-renal causes of renal disease includes obstruction to urine flow, and obstruction to urine flow is seen in urethral stone or in prostatic cancers. These are only few common causes of renal diseases. Then what to examine in the renal function test? Renal function tests, they are divided in 4 groups that includes urine analysis, blood examination, glomerular function test, and the tubular function test. Renal function tests are actually divided in 2 categories. Renal function tests, they are divided into glomerular function test and the tubular function test. In the glomerular function test, we assess the serum urea, serum creatinine, and the creatinine clearance test. And in the tubular function test, we perform urine concentration test, urine dilution test, para-aminohydric clearance test, and acidification test. And urine examination is important for assessing both the glomerular function and the tubular function. Common parameters which are assessed in the renal function test is the serum urea, serum creatinine, serum uric acid, total plasma proteins, serum albumin, and assessment of serum electrolytes, that is sodium, potassium, chloride, phosphate, and calcium. Normal serum urea level is between 15 to 45 milligrams per deciliter. Serum creatinine is between 0.6 to 1.3 milligrams per deciliter. Serum uric acid is 3.5 to 7.2 milligrams per deciliter in the males and 2.6 to 6 milligrams per deciliter in females. And total plasma protein concentration is approximately 6.5 to 8 grams per deciliter. Serum plasma albumin level serum plasma albumin level is between 3.2 to 4.6 grams per deciliter. And serum sodium level is 136 to 146 milliequivalents per liter. Potassium is 3.5 to 5.1 milliequivalents per liter. Chloride is 101 to 109 milliequivalents per liter. phosphate is 2.8 to 4 milligrams per deciliter, and calcium is approximately 8.8 to 10.2 milligrams per deciliter. Then the physical, then examination, chemical examination of the urine. So urine examination is an extremely valuable and most easily performed test for the evaluation of renal functions. This urine examination includes physical examination, which is also called macroscopic examination, chemical examination, and the microscopic examination of the sediments. In the physical examination, we see the appearance or the color of urine, volume of the urine, specific gravity, and the odor of urine. And in the chemical examination, we observe the presence of glucose, ketone bodies, bilirubin, urobilinogen, proteins, and the pH of urine. And in the microscopic examination, we observe the presence of cells, cast, and crystals in the urine as sediments. So as far as the physical appearance or the color of urine is concerned, urine is yellow in color, and this yellow color in the urine is due to presence of pigment urochrome. Normal color of urine is pale to amber color, and straw color of urine is seen in the urine with low specific gravity. Amber color of urine is seen when urine has high specific gravity. Cloudiness in the urine may be caused by excessive cellular materials or proteins, crystallizations, or precipitants of salts upon standing at room temperature or in refrigerators. Almost colorless urine is seen on a large fluid intake or in condition of chronic interstitial nephritis or in untreated diabetes mellitus. Colorless urine is also seen in diabetes insipidus and ingestion of alcohol or caffeine in diuretic therapy. Orange color of the urine is seen in fever or urticarias or vitamin A. Green color in the urine is seen due to Pseudomonas infection. Red urine is seen due to presence of red blood cells, hemoglobin, myoglobin, or porphyrins in urine. Black color of urine is seen due to alkaptonuria, and milky color of urine is seen due to presence of fat or WBCs. And also many factors interfere in the darkening of urine on staining. As far as the volume of urine is concerned, urine volume is very important for the assessment of fluid balance and kidney function. Normal urine volume is about 1 to 2 liters per day. Oliguria is a condition when urine output is less than 400 ml per day. Oliguria is observed in acute glomerular nephritis and in the renal failure and in the renal ischemia. And oliguria is also seen in dehydration caused by prolonged vomiting, diarrhea, or burns or obstruction of some area of urinary tract. Also, it is seen in cardiac insufficiency. Polyuria. Polyuria is the condition when urine output is more than 2.5 liters per day. Polyuria is seen polyuria polyuria is the condition when urine output is more than 2.5 liters per day. It may be due to increased water ingestion, or it may be due to diabetes mellitus or diabetes insipidus or tumors in brain. Anuria is a condition when urine output is less than 100 ml per day. It is seen in renal shutdown, complete urinary tract obstruction, and in acute tubular necrosis, and in glomerular nephritis. Then specific gravity. Normal specific gravity of urine is 1.015 to 1.025. Increase in specific gravity is seen in low water intake, diabetes mellitus, albuminuria, diabetes mellitus, and and increased specific gravity is seen on low water intake, diabetes mellitus, albuminuria, in acute nephritis, and decreased specific gravity is seen in absence of ADH or in renal tubular damage. Isostenuria is a condition where there is persistent production of fixed low specific gravity urine, isoosmolar with plasma, despite a variation in water intake. As far as the odor of urine is concerned, normal odor of urine is aromatic. In diabetes mellitus, patients' urine have fruity odor. In urinary tract infections, there is foul smell in the urine. Infants with inherited defect in amino acid metabolism, urine may have urine smell like burnt sugars. Then, as far as the chemical examination is concerned, we examine presence of glucose, ketone bodies, bilirubin, urobilinogens, proteins, and the pH in the urine. So, as you know, normal blood glucose level is kept within normal range of 60 to 100 milligrams in fasting state. After a meal, when glucose is absorbed from intestine, blood glucose level starts rising and reaching to maximum within 1 hour. In normal individuals, blood glucose level does not rise above 150 milligrams per deciliter. On the other hand, a rise in the blood glucose level above 180 milligram is called renal sugar threshold. It will result in the urinary elimination of glucose because amount of glucose filtered by glomeruli will exceed the amount which can be reabsorbed by the tubule. The maximum reabsorption capacity of a substance is known as tubular maximum. For glucose, renal sugar threshold is 180 milligrams per deciliter, and tubular maximum is 375 milligrams per minute. Then presence of ketone bodies. The three metabolic products, that is acetoacetate, beta hydroxybutyrate, and acetone, are collectively called as ketone bodies. In uncontrolled diabetes mellitus, due to low insulin concentration results in the increased lipolysis and decreased re-esterification and results in the increased plasma free fatty acid, and increased glucagon insulin ratio enhances fatty acid oxidation in liver. So in this situation, there is, due to increased oxidation, there is increased formation of ketone bodies. Increased excretion of ketone bodies, that is excretion of acetoacetic acid and beta hydroxybutyric acid, is seen in uncontrolled diabetes mellitus, and it is also seen in starvation. Ketone bodies are analyzed by a test called Rothro's test. Then bilirubin may be found in the urine whenever there is increase in the concentration of conjugated bilirubin in the blood, and increased level of conjugated bilirubin is seen in the obstructive jaundice. Urobilinogens in urine. Normal urine contains traces of urobilinogens, but in hemolytic jaundice, excretion of urobilinogens is increased. Then presence of proteins in urine. Protein urea is an indicator of leaky glomeruli. Small amounts of protein, usually less than 30 milligrams per day, is found in urine. 30 to 300 milligrams per day is called microalbuminuria. Macroalbuminuria is earliest sign of renal damage. Patients with diabetes mellitus are at high risk of suffering from renal damage. Early detection of diabetic nephropathy relies upon test of urinary excretion of albumin. Once diabetic nephropathy occurs, renal function deteriorates and renal insufficiency evolves. As glomerular damage increases, the permeability of membrane decreases. With an increasing proportion of high molecular weight proteins are also seen in the urine. The relative clearance of number of proteins have been measured to assess the selectivity of membrane and provide an assessment of glomerular damage. Then pH in the urine. pH of urine ranges from 4.5 to 8. Normally, it is slightly acidic, lying between 6 to 6.5. Alkaline pH is seen after intake of meal. On exposure to atmosphere, urea and urine splits causing release of ammonia, resulting in alkaline urine. Then microscopic examination. In the microscopic examination, we find cells, cast, crystals in urine under microscope. So in the microscope, we can observe hematuria. Hematuria is characterized by presence of abnormal number of red blood cells in the urine. The erythrocytes in urine are due to glomerular damage, trauma, are due to kidney stone, are due to nephritis, are due to upper or lower urinary tract infection. In pyelonephritis, there is presence indicates inflammation of kidney, and they are also seen in the cystitis, in urethritis, and in the prostatitis. Renal epithelial cells are excreted in nephritis and in pyelonephritis. Granulated casts are seen in pyelonephritis. Hyaline casts are present in normal people after strenuous exercise. Also, there are physiological or pathological presence of ammonium phosphate, magnesium phosphate, calcium oxalate crystals in urine. This is about the urine examination. Now, blood examination. Blood examination is done to measure presence, measure substance in blood that are normally excreted in kidney. Their level in blood increases in kidney dysfunction. As a marker of renal function, creatinine, urea, uric acid, and electrolytes are done for routine analysis. So changes in the serum analytes in kidney disease. As far as serum urea and creatinine level is concerned, they both are increased in renal disease. Urea increases more in glomerular disease as compared to creatinine. Urea is less reliable indicator than creatinine as it is affected by many factors such as protein intake, dehydration, muscle breakdown. They all affect the urea level in the blood. Then serum uric acid may increase in chronic kidney disease, but not sufficient to cause gout. However, raised uric acid is bad prognostic indicator of chronic renal disease. Total protein in albumin, both serum, total protein, and albumin is decreased in chronic renal disease due to increased protein urea. Even though protein urea may also be seen in acute kidney disease, but it does not alter the total protein and albumin in the plasma. Then, as far as serum electrolytes are concerned, sodium is decreased in and potassium is increased in chronic kidney disease as kidney reabsorbs sodium in exchange of potassium. Chloride and phosphate is increased and calcium is decreased in vitamins. Then changes in hemogram and urine analysis in kidney disease. Red blood cell count and hemoglobin is decreased in advanced stages of kidney disease due to deficiency of erythropoietin. Urine examination reveals protein urea is seen in both acute and chronic kidney disease as well as in kidney infections. Protein urea can be of two types. In initial stage, very less amount of albumin escapes in urine. That is, microalbumin urea is 30 to 300 milligrams per day. Frank protein urea, when it is greater than 300 milligrams per day. Best evaluated in 24-hour urine sample. In spot urine, albumin creatinine ratio is used to evaluate protein urea. Presence of red blood cell may indicate glomerular nephritis, acute nephritis, and kidney infections. Presence of pus cells, stress positivity, nitrites may indicate bacterial infections. Then blood urea and serum creatinine. Normal blood urea level, it is between 20 to 40 milligrams per deciliter, and serum creatinine level is between 0.6 to 1.2 milligrams per deciliter. More than 90% of urea is excreted through kidneys. Consequently, kidney disease is associated with accumulation of urea in blood. Urea is neither actively reabsorbed nor secreted by tubules, but it is filtered freely by glomerular. In normal kidneys, 40 to 70% of highly diffusible urea moves passively out of renal tubules into interstitium, ultimately re-enters in plasma. The big diffusion of urea is also dependent on urine flow rate, with less entering the interstitium in high flow state, such is seen in the pregnancy and vice versa. A number of external factors influence the circulating urea concentration. For example, plasma urea concentration is increased by high protein diet, increased protein catabolism, reabsorption of plasma and blood proteins after gastrointestinal hemorrhage, treatment with cortisol, dehydration. These all with decreased perfusion of kidney, that is in heart failure. These are all causes for increasing concentration of urea in blood. In the above renal, pre-renal situation, the plasma creatinine concentration may be normal. In all these conditions, where urea level is increased but creatinine is not increased. In obstructive conditions or in post-renal conditions, like in malignancy or in nephrolithiasis or in prostatism, both plasma, creatinine and urea concentration may be increased, although in these conditions, there is often a greater increase in the plasma urea than creatinine. This increase in the plasma urea level in creatinine is due to increased peak diffusion. These considerations give rise to principal clinical utility of plasma urine and can be used as a crude discriminator between pre and post-renal azotemia. For normal individuals on normal diet, the reference interval for the ratio of urea to creatinine is between 12 milligrams of urea to 1 milligram of creatinine. Significantly, lower ratio usually denotes acute tubular necrosis or low protein intake or severe liver disease, and urea synthesis is decreased. Increased plasma urea level with normal creatinine concentration give rise to high ratio may be seen with any pre-renal states as described earlier to you. High ratio is associated with elevated creatinine concentration, denotes either post-renal obstruction or pre-renal azotemia. Urea clearance is poor indicator of glomerular filtration rate, as its production rate is dependent on several non-renal factors, including diet and activity of urea cycle enzymes. A high protein diet causes significant increase in urinary urea excretion. In addition, variable amounts of peak diffusion will influence both plasma and urinary urea excretion. The measurement of urinary urea has little place in clinical diagnosis and management. However, it provides crude index of overall nitrogen balance. On average protein diet, urinary urea nitrogen is about 12 to 20 milligrams per day. So the reference interval for serum urea of healthy adults is 10 to 40 milligrams. Plasma concentration also tends to be slightly higher in males than females. High protein diet causes significant increase in plasma urea concentration and increased urinary excretion. Measurement of plasma creatinine provide a more accurate assessment than urea because there are many non-renal factors that affect the urea level. This is already explained to you. Non-renal factors can affect the urea level. This includes mild dehydration, high protein diet, increased protein catabolism, muscle wasting in starvation, reabsorption of blood proteins after GI hemorrhage, treatment with cortisol or its synthetic analogs. States associated with elevated levels of urea in blood are referred as uremia or azotemia. And causes are classified in pre-renal, renal, and post-renal. They have been already explained to you. Then serum creatinine. Creatinine is filtered but not reabsorbed in kidneys. Normal range is between zero point 0.8 or zero point 0.6 to 1.3 milligram per deciliter in male and 0.6 to 1 milligram per deciliter in women. Creatine phosphate is relatively unstable at pH, prevailing in the muscles and is non-enzymatically converted to creatinine. So creatinine is found from the creatine phosphate. This conversion takes place continuously in healthy muscle. This creatinine so produced is released in circulation and transported to kidney and is excreted in urine. And it has two important implications in clinical medicine. The first implication in clinical medicine is amount of creatinine excreted in urine over 24-hour period. This correlates with muscle mass. It is constant for a given individual. It is about 15 milligrams per kg body weight. The quantity of creatinine is measured in 24-hour urine specimen. And second important implication in clinical medicine is that creatinine is useful kidney function test because its level is remarkably constant. It is neither secreted nor reabsorbed in tubular systems, so its excretion during a specified time in a creatinine clearance test serves as measure of glomerular filtration rate. Creatinine is breakdown product of creatine phosphate in muscles and is usually produced at a fairly constant rate by body depending on muscle mass. Creatinine is filtered but not reabsorbed. Normal range is between 0.6 or 0.8 to 1.3 milligrams in male and 0.6 to 1 milligram per deciliter in women, not increased above normal until glomerular filtration rate is less than 50 ml per minute. The methods most widely used for serum creatinine are based on Jeffrey's reaction. This reaction occurs between creatinine and the picoate ion formed in alkaline medium. And this gives a red orange solution develops, which is red on calorimeter at 520 nanometer. Glomerular function test. The glomerular filtration rate is the best measure of glomerular function. Normal glomerular filtration rate is approximately 125 ml per minute. When glomerular filtration rate decreases to 30% of normal, this indicates moderate renal insufficiency. Patients remain asymptomatic with only biochemical evidence of decline in glomerular filtration rate. As glomerular filtration rate decreases further, severe renal insufficiency characterized by profound clinical manifestations of uremia and biochemical abnormalities such as acidemia, volume overload, and neurological, cardiac, and respiratory manifestations. When glomerular filtration rate is 5% to 10% of normal, this is end-stage renal disease. Then renal clearance test. What is meant by clearance test? Renal clearance of a substance is identified as the volume of plasma from which the substance is completely cleared by kidneys per minute. What is creatinine clearance? Creatinine clearance is defined as the volume of plasma from which creatinine is completely cleared by kidneys per minute. Then renal clearance test. In renal clearance test, the substance which are used for clearance test is the endogenous creatinine and endogenous urea. And exogenous substance used for clearance test is inulin. Renal clearance test used to assess the rate of glomerular filtration rate and renal blood flow. Creatinine clearance test, it is based on the rate of excretion of the kidneys of metabolically produced creatinine. Creatinine is freely filtered at the glomerulus and is not reabsorbed by the tubules. Creatinine clearance means to compare the creatinine level in a 24-hour urine sample with creatinine level in blood. Creatinine clearance also helps to estimate glomerular filtration rate. This test provides information about the severity of kidney disease. The amount of blood that the kidney makes creatinine free each minute is called creatinine clearance. Creatinine clearance in young person is about 125 ml or 120 ml per minute, meaning each minute that person kidney clears about 120 or 125 ml of blood free of creatinine. So normal creatinine clearance is about 9 to 120 ml per minute, and decreased creatinine clearance results in decreased glomerular filtration rate. Now the procedure for calculating creatinine clearance. Specimen collection includes both a 24-hour urine specimen and serum sample, preferably taken at midpoint of 24-hour of urine collection. Volume of urine is carefully measured and concentration of creatinine in both serum and urine is determined. Creatinine clearance is calculated by using formula U into V upon P, where U is urine creatinine concentration, V is urine volume excreted in 24 hours, and P is the serum creatinine concentration. And corrected creatinine clearance is a normalization factor of 1.73 upon A is used for the purpose where 1.73 is the generalized expected average body surface area in square meters, and A is patient's body surface area. Accordingly, creatinine clearance is modified for surface area is calculated as U into V upon P into 1.73A. Inulin clearance. Normal inulin clearance is 120 ml per minute. It is method of choice for determination of glomerular filtration rate. Freely filtered, it is freely filtered and neither reabsorbed nor secreted by tubules. So inulin, what is inulin? Inulin is homopolysaccharide made up of fructose, and it is neither reabsorbed nor secreted by renal tubules. So its clearance is equal to glomerular filtration rate, and it is administered intravenously to measure glomerular filtration rate. However, it is more convenient practically to estimate clearance of substance already present in the blood. For this reason, creatinine clearance is preferred over inulin. Then tubular functions test. In the tubular function test, we perform urine concentration test. The ability of kidneys to concentrate urine is a test of tubular function that can be carried out readily with only minor inconvenience to patient. Like this test requires a water deprivation for 14 hours in healthy individuals. A specific gravity of more than 1.02 indicates normal concentrating power. If specific gravity is 1.008 to 1.010, it is isotonic with plasma and indicates no work done by kidneys. The test should not be performed on dehydrated patient. Then urine dilution or water load test. After an average fast, the subject empties his bladder completely and is given 1000 ml of water to drink. Urine specimens are collected for the next 4 hours. The patient emptying bladder completely on each occasion. Normally, the patient will excrete at least 700 ml of urine in 4 hours, and at least one specimen will have a specific gravity less than 1.004. Kidneys, which are severely damaged, cannot excrete a urine of lower specific gravity than 1.010 or a volume above 400 ml in this time. The test should not be done if there is edema or renal failure or water intoxication may result. Then the differences between the glomerular dysfunction and tubular dysfunction. In the glomerular dysfunction, there is blood urea increase. In tubular function, urine concentration is decreased. In the glomerular dysfunction, there is increase in the blood creatinine, there is decrease in the inulin clearance, and there is decrease in the creatinine clearance and urea clearance. Para-amino hippuric acid clearance is also decreased. Proteins in urine are present, urine volume is decreased, specific gravity is increased, and blood phosphate is increased. In tubular dysfunction, urine concentration decreases, urine dilution tests are normal, uric acid excretion is decreased, blood uric acid is increased, amino acid urea is present, acidification of urine is decreased, urine volume is increased, and phosphates are decreased. This is all about the renal function. Yes, we stop.